Good afternoon, dear colleagues. This is my great pleasure to be introduced to your society today and a great honor for me to join your international meeting as a speaker. My name is Dr. Uliana Dorofaeva. I am a medical director at Ovogene Donor Bank, and I'm practicing infertility since 2006. Today, I am going to share with you our practical experience regarding oocyte donation and maternal surrogacy in Ukraine. As we all know that we are experiencing treatment of IVF all over the globe a little bit more than 40 years. And oocyte donation treatment is not that recent. However, oocyte vitrification, we are practicing it a little bit over than 10 years so far. Right now, oocyte donation is an integral part of modern assisted reproductive care, and it is associated with achieving the highest success rates. All over the globe, the number of couples experiencing fertility problems is over 90 million people, and about 10 to 50% of those couples would request oocyte donation. A recent completed data from Azure Registry is saying that 65,000 cycles were performed mostly in several countries in Europe. And you can see listed those countries that where over 1,000 treatment was performed. Of course, nowadays, recently, before COVID, that numbers were absolutely different and much higher. And Ukraine was also in that list. And here we can see only those treatment cycles which were completed for the patients who were traveling to Ukraine to complete and to receive these treatment cycles. We do not count here cycles which were exported out of Ukraine as an oocyte banking. So this is true that the many of infertility patients, they need to travel abroad in order to receive the treatment they would request or the only treatment which will be effective for them. They are looking for the higher quality care and services. They are looking to reduce their costs while they cross border for the medical treatment. They are looking to combine their medical treatment with the attractive destinations. However, the most important is the fact that the treatment or medications are not approved or available in their home country. Recently, the whole world was facing some problems, even having been able to provide this kind of treatment, and that was COVID. And for my home country, that unfortunate situation is continuing, and it even worse now because for 4 months we are in the status of the war. And this is a real war when we had to go abroad in order to be safe for us and for our kids. We even took all our stored biological materials from the clinic and we sent them for the safe location in Europe because we are very responsible and we are responsible for the biological materials of our patients. That's why we need to remember that oocyte donation and surrogacy are those treatments for which many patients would need to travel and they would need to search for the options where the treatment will be effective, that it will be highly successful, it will be safe and reliable and with the great care about the patient. The fact is, and this is the data from the UK registry, that every decade, age of a woman delivering the first baby is increasing for 2 years. And if the trend will continue, the first deliveries will be happening in 51-year-old in 2100. And we as reproductive doctors need to be prepared for this, as oocyte donation is one of those treatments which still is effective and is going to be effective. Of course, we know, and we are also practicing this kind of the experimental treatment as the mitochondrial donation and the pronuclear transfer. However, still it even worse in terms of the regulations in the different destinations. People are going to live longer, and we know that there are many techniques for this. Women are looking better in their different ages. However, the oocyte rejuvenation techniques are, we know the effectiveness of them, and everything, even if something works, it needs to be started in advance or in a right in a right term. That's why many of the patients and the trends for the further growth would be the following, that the need for oocyte donors is growing steadily globally. The introduction of and improvement of oocyte vitrification techniques has led us to the significant improvement in survival rates, which has allowed the development of the oocyte banks. Combining supply and demand promotes the development of logistics and the cooperation between the clinics and the countries. The global epidemic and existing restrictions have particularly affected the developments of export and import of the biological materials. For the patients and for the clinics, options of the oocyte donation treatment are the following: that mostly patients can fly into destinations where oocyte donation treatment is performed, or donors are flying into those destinations if it is regulated and legal, but still the number of the oocyte donors or their variety is not high enough. There could be an embryo creation options that the sperm is transported and the embryos are created into the one destination and then they are sent to the final destination where the treatment is going to be performed. And we have a practical experience on sending either fresh in the transport incubators, however, still facing some difficulties and it's not always safe, or vitrified embryos, which is more as a global practice. However, the oocyte banking has loads and loads of benefits compared to the previous options. You can see in the map, this is everything what is green. These are the destinations to where we were sending or keep sending biological materials right now as an ovogene donor bank. In order to be able to do that, the most important is the certification and the accreditation of the donor bank and all the processes involved. As we all know that there are different regulations in the different countries, such as FDA regulation in the US, Human Fertilization and the Embryology Authority in the United Kingdom, European directives in the Europe. However, still many clinics and the countries would have and would request to follow their local laws. In Australia, Brazil, South Africa, they are all different and we need to know, and we do know them, and we are following the processes. Something what is the most important and what is joined for all these locations, this is the fact that as the production unit, as a clinic or the network of the centers which are providing biological material for the bank, as the affiliated centers, there should be a quality management system running in place. It needs to be as a rule for the establishment of the international activities for the oocyte banking, and not only, also for performing an IVF treatment. And it should be fully compliant with the EU regulations, IHFA regulations, FDA and the Health Canada, RTAC requirements, ASHRA, ISRM, REDLARA, and different bodies and the committee's recommendations for donor selection, evaluating and testing, producing, storage and transportation of the biological materials all over the globe. As the basic, there is an ISO 9001-2015 standards, and the SOPs and the quality management procedures should cover all the critical steps in donor selection and screening, scoring, cryopreservation, sewing, packaging, identification, labeling, traceability, not only for the biological materials, but also for the equipment and the materials which are used for the operations, quality control of the working environment, non-conformance management, quality audits and the risk management, management of the documentation, staff training, and the constant improvements. This is something that really helped us once we were facing the issue of the immediate transportation of the biological materials, as all the documentation and all the data is stored in the cloud and it's safe. So we should not keep all the papers. Of course, the original papers are also still kept in Ukraine in the secure place. However, we have access to all the information as all of our international patients and the clinics and the partners as well. Key performance indicators to evaluate the process to reach the targeted goals as the high quality and the efficiency is to have the opportunity to vary and the quality of the donor materials to comply with the internal quality control requirements and the external quality assurance, and to achieve the highest possible outcomes with our partner clinics globally. The inclusion criteria for the donors are the following: between 18 to 29-year-old. Even the law is saying that we could recruit donors up to 35 years old. However, I'm going to show you lately the efficiency and the outcomes based on the donor age and how we get into the decision that 29 should be the cutoff level. The proven fertility as a unique factor, almost unique as all over the globe, is differently regulated. Donors should be physically and mentally healthy. They should have no hereditary habits. They should have appropriate ovarian reserve, and this is also an inclusion criteria. They are dependable, mature, and the responsible persons. And of course, they are excluded if they have no information about donor family history, if that recommendation was given by the psychologist or the genetics not to proceed with the oocyte donation, if they had the positive drug test or they were tested positively for the infectious diseases, or they are the carriers of some genetic mutations, if they have low survival rates in their previous sowing cycles. So the selection criteria according to the laboratory tests and the diagnostic tests and the genetic tests, you can see as the most important tests in the list right now. However, it is not complete because also we are providing extended genetic testing for almost like more than half of our donor database. They all are having their extended genetics done. And we are also going to share that data with you. The genetic counseling process for each donor also include the interpretation of family and the medical histories to assess the chance of the disease occurrence or the recurrence, the 3-generation pedigree of the donor and the analysis of that pedigree and the diseases, genetic screening recommendations by the geneticists, genetic tests which are performed for all donors is the karyotyping, cystic fibrosis, spinal muscular atrophy, Fragile X, phenylketonuria, and the neurosensory deafness. And it's only based on the variety and the frequency of these mutations in the Eastern European population. However, right now, once we started the recruitment of the different populations and in the different countries, we decided to go for the pan-ethnic panel and to increase the accessibility for our oocyte donors and for our individual patients and the clinics, the extended genetic. So the extended genetic testing for this, not for the special cohort of the donors, but for most of them, is done for 3,002 mutations. And we store DNA for all of our donors, so we will have the opportunity to test further if there is such a need. And this is the result of the genetic testing for the 302 gene panel. And you may see that we were so surprised seeing that only 14% of our donors, which were tested for 3,002 genes, were non-carriers of any disease. 10% were carriers of the cystic fibrosis, and you can see the different other mutations which were as mostly commonly finded. And these are from the list of the critical mutations and non-critical mutations, also the following here, and the hemochromatosis was number 1 with the presence of 25% of the donors being carriers. So it says that the most we test, more mutations we will find, of course, but we should not exclude all of them. However, any committee decision would tell us that we are able to use these donors without genetic matching. So what we are recommending to our patients and to the partner clinics to do the genetic matching, to test your partners of the couple, and then to do the genetic matching in order to provide safe treatment for them. Psychological evaluation is also important, and it concerns the interest of the donor, the interest of the recipient, the interest of the donor program, and also the clinic for everything to be safe, and the interest and concern of the interested all parties, including the societies and the future children. Some countries, it's obligatory to have the psychological evaluation to be performed by the certified psychologist, for example, as an MMPI psychological counseling for the United States or the ANZICA counseling for Australia. Infection diseases screening, of course, is performed for all donors. However, the method of testing, the frequency, and the fact that the biological material need to be quarantined or not is different according to every country regulations. This is just as an example of the infection screening requested by the IGFA. So all donors which are going to be used in the UK need to be tested in ISO 15189 certified laboratory. It should be both serology and the PCR with the repeated PCR after a certain period. So the testing is really deep and complete. I would like to share also our data regarding the numbers of the donors being included into the program after the initial donor contact was performed as a phone interview or the online form. Only about 1/3 of them was accepted after the personal or psychological social evaluation. Some of them, they were not accepted due to the medical reasons. Very little percent, but still they are excluded after infection disease screening and after genetic screening and the genetical consultation. So about 3 of 10 candidates will become our donors. It also comes from the good clinical practice recommendations and the information provision for those using and practicing the reproductive donations. Here we can find also all the paperwork and the consents which needs to be signed by every donor. Donor age, as I said, is differently regulated in different countries. Mostly, donors are allowed between 18 to 36 years old in most of the European countries. Some do not put the upper age limit, like Bulgaria and the Denmark. In many countries, it can be known donor or the relative. That's why you can see also in the UK, we will see it a bit later, that probably because the number of the donors available locally in the country is very limited and the relatives are going to donate, even some donors are over 40 years old. So this is the efficiency based on the donor age coming from our database. And we may see that the most effective treatment for using the oocyte donors, we are getting in the group between 24 to 27 years old. And the lowest efficiency is coming from the group 30 to 35 years old. That's why such donors are excluded from our database, and we do not perform treatment for donors over 29 years old. However, also the donor database changed. We were evaluated the average age of the donors in 2010 in our database, and 1,654 profiles were evaluated, and the average age of the donor was 23.7 years old. And in 2020, 2,548 profiles were evaluated with the average age 25.2 years old. It's also the fact because Ukrainian donors, and they are about 70% of our database still, they need to have a proven fertility. That's why they are starting to get their children later. That's why they are getting like older while they are donors. So this is the IGFA information update from 2017. And you may see here that under exceptional circumstances, every year, they have, in the UK, they have donors between 36 to 40 years old, between 41 to 45, and even 45-year-old. And the median, the average age is 31-year-old for all these data. Proven fertility for donor is required only in few countries such as Ukraine, Belarus, Bulgaria, and Hungary. Donor must have at least one child of their own. All other countries, they do not request that. If we are talking about the medical side for the oocyte donation, so recently the gold standard changed, and the gold standard for the oocyte donation right now for safety of the treatment for the oocyte donor is, of course, the protocol with gene-rich antagonist and the agonist triggering. The applications of the oral contraceptive pills for planning the program was changed, and now we do not use the oral contraceptive pill. However, we are using estrogen priming or progesterone if that is needed for some kind of the synchronizations. We are using random and the luteal start stimulation. And the programs, when we use the fresh donor material, we completely changed to the vitrified donor oocyte. As well, we are practicing progestin primed ovarian stimulations. And the targets for the stimulation protocol, it should be the one which produces a homogeneous cohort of mature oocytes, optimal number of well-expanded cumulus oocyte complexes with no inconveniences or risks for the donor. We have our table, which we share between the doctors, of the dosage of the medications for donor stimulation based on their IMH, age, and the BMI. However, it's only for initial cycle stimulation, and we are for individualization. We do not have a standard approach for all donors. We do manage asynchronous growth in the oocyte donation cycle using estrogen priming, progesterone supplementation. We do not do step down, and quite often we do random start. So the key points for the stimulation is the recombinant human follicular stimulation hormone alone, and it's sufficient for follicular development in the normogonadotropic patients who are our donors. It's a full control of the cycle to achieve the individualized number of the oocytes with optimal amount of the medications which being used and with no complications for a donor. Oocyte number and the used oocyte and embryo rate are strongly correlated, meaning that while we are willing for the optimal number, still more oocytes we are getting, more embryos we are creating if this is a good donor and a good responder. And then the higher cumulative or the multiple pregnancy rate from one donor cycle is achieved. Gene-rich agonist trigger represents the gold standard, of course, for all oocyte donation cycles. And these are the schemes of the ideal protocols for the oocytes donors which we are using. And again, as I said, many of them are in their random start. This is data from Ana Cobo and the big group of Spain, saying that clinical pregnancy rate is related to the number of the oocytes which we are using. And you can see as a maximum number, even 43 oocytes will bring us to the clinical live birth rate, not even clinical pregnancy rate, of 97%. This is our clinical and the embryological parameters in correlation with the cohort of the mature oocytes received. And in our medical key performance indicators, we do say that we would like to receive between 12 to 30 mature oocytes from the cycle. And you can see 4 groups, 1 to 11 oocytes, 12 to 24, 25 to 30, and over 31. So the percentage of the used oocytes is the worst, while we are receiving less oocytes. We do not really like to receive less than 12 oocytes in our donor stimulation cycle. This says that we do something wrong. Either the inclusion criteria of the donor were wrong, or the stimulation, or the dosage of medications, or her full response. However, while we are receiving over like close to 30, over 20, close to 30, and even sometimes, not commonly, however, sometimes we do receive over 31 oocyte, the difference of the is in number of the mature oocytes a little bit, it's not significant. And in the number of the oocytes which are selected based on the morphological criteria for those which we are going to use for the oocyte banking. However, the efficiency is not changing and cumulative is still high. So these are key performance indicators. Clinical, we are calculating average number of the harvested oocytes, and you can see critical, minimum or maximum, optimal, and the desired number. Mature oocytes rate, utilized oocytes rate, and we do calculate less than 12 oocytes and over 30 oocytes. Not only clinical indicators are important for the oocyte banking, however, really important is the embryological laboratory. And the embryological laboratory for the oocyte banking should be designed as a smart laboratory concept with automatic quality control system. That should be a great team of the senior embryologists and the clinical embryologists who are working for the egg banking and who know all the details regarding oocyte morphological selection and all the details. Embryological laboratory quality system should be designed also according to the international guidelines and the EU directives and the CAP strict criteria. And all the disposables and media should be also certified. Tissue bank witnessing is important. Laboratory audit system using the advanced technologies and the genetic technologies for the oocyte banking, artificial intelligence, and the high quantity and totally transparency with the supplier clinics or with the partner clinics in terms of the embryological performance and the services. So we do evaluate morphological parameters of each oocyte, which we are selecting for the oocyte banking. And these morphological criteria are the following: as a cumulus oocyte complex morphology, zona pellucida, perivitallin spaced, first polar body appearance, oocyte shape, meiotic spindle location, granulation of the cytoplasma, and time-lapse activities for the oocytes. So we divide all the cohort of the oocytes, which we are going to receive in one stimulation, into 3 categories: quality 1, quality 2, and the quality 3. So ideal oocytes, according to the oocyte morphology, are categorized as quality 1 and are going to be used for the oocyte vitrification for the oocyte banking. Quality 2 of the oocytes was a little bit fragmented polar body, small to moderate perivitallin space, some debris in the PVS, some small vacuoles, small granulosity, a little bit irregular zona pellucida, and etc., are qualified as quality 2 oocytes. They can be used for ICSI and for the fresh fertilization with the future further development of the embryos. However, they are not selected for the oocyte banking. And the morphology of the oocytes, which are worse, are categorized as a quality 3, and they are not used for any of the treatment for our patients. A long time ago, it was probably 2013, when we calculated and we were thinking which oocytes we should include into our clinical practice and which we should exclude. So those oocytes which were categorized as a quality 3, you can see their efficiency. We took 421 oocyte, of course, with the guarantees for the patients, and it was consented. The survival rate for this category was really low, as 68%. Fertilization rate as well lower. Good quality days 3 embryos, 28%, high quality blastocyst 18. Embryo utilization rate still was high. However, we were losing so many materials on the way. That's why we decided not to include these materials for the future use anymore. And since 2013, we do not include them into our clinical practice. Advanced technologies which we are using for the oocyte selection. This is artificial intelligence through the time-lapse phase contrast microscopy, NGS-tested donor oocytes, electronic witnessing for the whole process, meiotic spindle determination prior to the donor oocyte freezing, time-lapse video recording, and live image during vitrification process for each oocyte lot. You can see the oocyte survival rate per clinics. They are different, and we have a cutoff of as 80%. Right now, we started to experience visit of our clinical embryologist or the laboratory director for the opportunities to teach the clinics and to educate them how to warm the oocytes before they are starting the initial process of the treatment. And we do not recommend for the clinics to continue working with the oocyte banking if their results are lower than 80%. We immediately make the audit, the visit, and we start to exchange our experience in order to get higher. And you can see many clinics are doing really good. They are over 90% survival rate, and they have really wonderful clinical experience and clinical results. Just several examples of the clinics, how we do evaluate monthly their efficiency, and all the data which is red, it is something what is critically low or high. Optimal is yellow, and the green is ideal or the desired level. So we do care about this efficiency for all of our partners, as this is our reputation, of course. The ISRM Practical Committee is saying that we need to be in the data between 90 to 97% survival rate after sowing, fertilization, implantation, and the pregnancy. So pregnancy per one sowed oocytes should be between 4.5 to 12%. And it's absolutely achievable while we are taking care for all the parameters which we were saying. The truth is that more oocytes are recommended to be used by the patient, the higher efficiency they will get in a complete egg donation cycle, or the cumulative clinical pregnancy rate will be higher, of course. Also, we did evaluate the fresh donation cycles. It was quite widely recommended, and you probably still can see in your communication with your patients that sometimes they are asking for the fresh oocyte donation. And we did calculate the number of cycles as a fresh, which we fertilized, and the full donor was used for this kind of treatments. And the average number of the oocytes collected in that cases, it was 236 fresh egg donation cycles. It was 21.3. The average number of the blastocysts per cycle was 6. With the clinical pregnancy rate per embryo transfer 53 and cumulative clinical pregnancy rate as 86%, number of the surplus embryos in all this group of the patient was 503. And the estimated return of the patients, of this cohort of the patients, because the average age of that patient is 43-year-old, and mostly they do wish to have one child, and that's it. So only 16%. So in this time when the oocyte donation is so much needed in different countries and for different population of the patients, we think that we should not waste the donor material and to recommend the full donor cycle. We should really optimize the usage of the donor oocytes by providing the treatment using 6, 8, 10, 12, based on the requirement of the patient and the probability for that patient to be pregnant in the first cycle, including their status of their infertility, their status of their uterus, endometrium, previous treatment, immunological infertility, etc. However, we do know how to use these prognostic factors in order to optimize also their chances, but also to optimize the number of the oocytes we are going to use. We all know that the rate of the genetic abnormality based on age is different, and I would like to bring your attention to the fact that even for the young women, which is the category of the oocyte donors, we still see the genetic abnormalities in their cells, and it is around 30%. Why it is important to say right now, because as one of the services, and this is a unique service what our group is offering, we do offer NGS testing of the donor oocytes. And we did 1,978 oocytes as a test oocytes, and the euploid rate for these oocytes was 74.9%, meaning 25% of the oocytes, of the donor oocytes categorized as quality 1 according to the donor oocyte morphological selection. After we evaluate the polar body genetics, like the NGS testing was performed, we found that the 25% of those oocytes were uneuploid, meaning that if we want to optimize the outcome of the treatment cycle using the oocyte donor NGS testing, this is an option. And after NGS tested oocytes, we were close to 80% of the blastulation rate in the oocyte donation and very high euploidy rate for the further cycles. That's why this is something what is really may be considered to used widely. This is the embryological data, how we see the spindle and how to make the ICSI and which pictures the clinic is receiving after the testing of the NGS testing of the oocytes was performed in order to find the proper location to make the ICSI. And while it needed to be discussed between the embryological teams, I am not really an expert on this. However, while we are recommending or the clinics have an interest to use the NGS testing, the oocytes, of course, we do share all this data in all the details. As well as in Ukraine, that was possible. Right now, we are located in Europe. That's why we cannot continue that kind of treatment. So we do travel to Albania for this kind of techniques, but we do perform mitochondrial donation and the pronuclear transfers for those patients mainly who have the mitochondrial diseases, but not only, also for those who are not ready to consider oocyte donation as the only treating option for them. So in order to conclude, the oocyte banking is the best solution for effective egg donation treatment right now. Dedicated teams of the professionals should be involved both as the doctors and the embryologists. Effective implementation of the oocyte vitrification has made it possible to discover new therapeutic opportunities in the reproduction. The use of the vitrified oocytes can be considered as a new gold standard in reproduction. Individual approach for each patient and cycles allows us to effectively influence the result, and this is not only for the patient, however, also for the donor. Once all critical, clinical, embryological, and organizational aspects are considered, result of the cross-border cooperation will be the highest. And new trends are actively on a research phase and will become a routine probably soon. And very few minutes for the surrogacy in Ukraine. So the legal basis of surrogacy in Ukraine, it is fixed in the Ukrainian family law and determines the following. That officially married couples can use surrogacy if they have the medical indications. And the success rate, of course, is the highest while we are using own oocytes in a young population of the patients up to 35 years old, or the donor oocytes as a fresh or as the vitrified. However, right now, due to the situation as a war status in Ukraine, we do not recommend to continue surrogacy, and many, like, it's on hold. I really believe that soon it will become possible. However, even for our patients, we do recommend either to wait or to move their biological samples to another countries, and many of them are moving them mostly to Georgia or Albania or Greece or Canada or US. However, Canada and US are not really close to potential as it was in Ukraine, mostly due to the costs. However, right now, I hope that in the nearest future, we will come back to safe treatment, also using the surrogacy, because we had to move our surrogates out of Ukraine in order to keep them safe as well. So I will be happy to talk about this option really soon once everything is fine in our country. I would like to thank you for all your attention. I would like to wish, and I believe for the very soon it will be victory for Ukraine, and I will be able to be fully involved back in my great country for the practicing the IVF. And I will be happy to answer any questions which you may have. Thank you again for this great opportunity. You have my email here in case you would need to contact us. Thank you so much and have a great day.